Hello, and welcome to our webinar on what do we mean by well-governed, an exploration of clinical governance in universities. My name is Dr. Gareth Hughes, and it's my pleasure to be guiding you through this recorded webinar, and I hope it will be of use to you in your work. So let's start, shall we, at the very beginning, and we'll think about what do we actually mean by clinical governance. And it's important just because when we use that term clinical governance, sometimes we can become a little bit kind of worried or concerned about what it actually means. It's actually a relatively straightforward concept, and it's simply talking about good ongoing oversight and management of services to ensure that they're as safe and effective as possible. And built into that is a particular commitment to ongoing learning and improvement, so that in our work, we continue to learn from what happens. We gather data, we gather evidence, we learn from that, we seek improvement, and then we learn from that again. So it's actually just really the ways in which we oversee our services and manage them and ensure that they're delivering what we need them to deliver, and that we're ensuring that they're constantly improving. Whilst obviously universities themselves are not clinical spaces, it is important to recognize that they do provide clinical services, and they have done for a long time. And I know sometimes people get a little bit concerned about the use of the word clinical in relationship to universities. But I think it is important to recognize that some of the services that we have would meet the kind of broader definition of clinical, services like counselling services, for instance. And in the UK, we've been providing those kind of supports for student mental health for a very long time. First university counselling service seems to appear in the UK in the 1950s, probably in Leicester. And since then, university counselling services have kind of grown. Important to also recognise that at one point, most universities in the country also had their own health centre. They had their own GP surgeries, which would also have been overseen by proper governance. So this isn't a new concept to introduce this into universities. It's just one that we haven't perhaps paid as much attention to. And any clinical service that we're providing, or anything that might appear to be a clinical service, so anywhere where you've got a mental health professional in a mental health role supporting students who are experiencing problems with their mental health, that requires good governance around us to ensure that the care that's being provided is safe and effective overall. Now, one of the things that we need to be really clear about right at the very beginning is this isn't about being prescriptive about exactly how services are organized and how exactly people should do their job. We recognize that no two universities in the UK are exactly the same. And to try and have one specific service design for the sector actually is probably going to be really unhelpful. And we also know that from the research that interventions generally work much better in mental health when they're adapted to local context and to the users of that particular service. So what we advocate for instead is a principles-based approach, that we have some key principles of governance that are set out in the principles of good practice in the Charter framework that we ask universities to meet. So just to bring it back into thinking about what we're talking about, any service, any clinical service that's responsible for providing direct care for a health-related problem or illness. And it's important to also just acknowledge the fact that it has always been the case that universities get to choose what services they provide. But whatever service you provide, you are expected to provide to a reasonable standard. And that is the standard that would be set and expected of any other similar service elsewhere. So this covers, say, counselling services, mental health teams, nurses, GP surgeries, if you have them on site, anything that's directly related to what might be interpreted as some kind of healthcare. I'm going to talk about a little bit about medical model a little bit. That doesn't assume a medical model of healthcare, but it does mean that anything that might be recognized as such, you need to be providing to a reasonable standard of competency as it would be recognized elsewhere. And really important to recognize, this matters whether the services are provided in-house or whether they're contracted out. Because you are making the link between the student and the service and you are contracting in the service, you would still be responsible for ensuring that proper clinical governance is in place. So you'll be responsible for making sure that governance is in place. And also, just alongside all of that, we also have to think about the fact that the legal guidance to the sector for many years now has been that any member of staff who's providing support for mental health to students would be judged against the standards of a clinically well-governed service or a competent mental health professional. So this would include a member of academic staff. If a member of academic staff is attempting to provide ongoing support to a student who is mentally unwell and something goes wrong, then they would not be judged by the competences of a well-meaning academic. They would be judged against the competences of a mental health professional. So we really need to make sure our services are absolutely able to demonstrate that they can meet those standards that might be expected of them externally. So why clinical governance? Why is this important? Well, one of the really important things to always bear in mind when you're working in the field of mental health is that any intervention at all has the potential to cause harm, even when it's delivered by qualified professionals. And we see a wide literature. Now, I'm a psychotherapist myself. I live in the counselling world, and I absolutely believe that counselling is a really powerful, really helpful intervention, particularly for students. The research around the impact of counselling on students is really, really good. But it has the potential to cause harm. Um, and so what we want to see instead are really embedded systematic approaches that ensure the services and interventions that are provided to students are safe and effective. And those are the two really crucial bits of governance that we need to be able to see, that we know that they're safe and effective, and that we can demonstrate that they're safe and effective to ourselves and to other people. You know, when I'm talking about harm, it's important to also think about the fact that there are a number of ways in which we can do harm through our practice and through our services. The first, obviously, is direct harm. And, every now and then in the national press, there is concern raised about the fact that, misconduct or poor practice or unethical behavior can obviously have an impact on clients who access counselling, for instance, or any mental health service. It might also be that actually sometimes people experience adverse reactions to interventions. Sometimes interventions are incompatible, or people might be contraindicated for a specific intervention that would be problematic. And if they receive that service, then it can actually do direct harm. So we need to be really clear that we are doing everything we can to make sure that direct harm is not going to happen in our service. And that's tricky to do sometimes, because most of those services, most of that support is provided behind a closed door between a member of staff and a student. So, one of the key questions I think for us very often is, if something was going wrong, if we had a member of staff who'd gone off the boil for some reason, or who had picked up some strange ideas or some unhelpful practice, how would we know? What would tell us? How would we know that harm was actually happening in those realms? The second thing is that harm can also happen indirectly, because it takes an awful lot of courage and energy and motivation for someone who is experiencing difficulties with their mental health to actually get through the door and say, "Can you help me?" Now, if what happens when they go through that door is that the response that they get doesn't help, what we tend to know from the research is very often people don't then go and look for something else. They just think, well, I tried help and it didn't work. And that help is just a big, broad, sweeping help of all the different kinds of help that are out there. It's like, well, yeah, I tried to get help. It didn't work. So there's no point in me trying again. And as a result of which, we can reduce their likelihood to access support that can actually then kind of increase risk in the future. And so we can do harm there by kind of not meeting the hope that the person brought into the room with them. Also important to recognize, of course, that in mental health, nothing works for everyone. Every intervention that we have, which may be helpful for some people, is also likely to be unhelpful for other people. We get this kind of U curve very often, where an intervention will really help some people, and maybe really quickly, give a little bit of help to some people, have no impact on some people, and might actually do harm to some people. And so every intervention that we're delivering, we have to be really careful about that. We have to be using good informed judgment, good ethical insight, and a fair degree of skill to make sure that it's much more likely to help and unlikely to harm. And if we pick up that something isn't working, that we're able to respond quickly and get the student to some other support that might be more helpful. So what clinical governance does is that ensures that the foundations within the service are already in place to make sure that the outcomes that are delivered are as good as possible, that we're able to evaluate the impact that we're having and recognize where problems are when they occur. And we can ensure that actually our service continues to improve, that we're able to drive ongoing improvement so that as time goes on, students get better and better and better support from the services that we're providing. Now, I promised I'd come back to medical model earlier. Does this mean we're advocating for a medical model? It absolutely does not mean that at all. Irrespective of the approach that you take, the governance that you put in place is really important. And whether you're taking a social or environmental or behavioral or any other approach to mental health, they all still have the potential to cause harm. And if you look at an example of something like mindfulness, for instance, which many people advocated, and not, I would say, the originators of mindfulness and the people who did the research on it, important to note, but many other people were saying, oh, we should be delivering mindfulness as a universal intervention. No, actually, the people who did a lot of the research on mindfulness were themselves sounding an alarm bell at that point, saying, actually, there's a proportion of the population who are contraindicated for mindfulness. That is, that if they engage in mindful practice, their mental health will get worse, and in some cases, significantly worse. So this was really clear in the evidence. And then people did try and implement this in a universal way within schools. It didn't particularly have a huge average positive effect. Some people gained from it, some people didn't, but there were some people who seemed to have a negative impact of it. So again, you don't have to be taking a medical model approach to have the potential to do harm. Anything that we do has the risk of doing some kind of harm. So we need to have proper governance in place to make sure that it is safe and that it isn't having a harmful effect. So we're not requiring a medical model view. It just means we need to have proper safeguards in place and to make sure that our interventions are helpful and to minimize the risk of harm and to make sure that whatever we're doing and whatever approach we're taking, we are having a good impact and we're constantly seeking improvement. Now, there are in the medical world a lot of models of clinical governance out there. I just flag up a few here from the NHS, from the CQC and from the World Health Organization. But these are particularly fitted to medical environments. And so I'm just flashing them up here to make you aware of them, but they're not the thing that we would advocate for. And they're certainly not the things that we would be looking for as we go through an award process, because I think these are fitted particularly, as I say, to medical environments. So what we would instead say is think about your whole university approach and look at those elements that are going to be really important to ensuring that those services are actually safe. And we're going to talk our way through some of those in the session today. We're going to look at staff, leadership, making sure the service is evidence-led, looking at the whole service design, ongoing quality improvement, student voice, risk management, and information management. Before we come to that, though, it's probably worth just thinking about how all of that fits together in an overall structure. And there are kind of 4 elements of governance that might be useful to think about and useful to engage in. So the beginning bit is the organization. So this is kind of what's there before any student steps through the door. So how is your service structured? How is it organized? What kind of staff have you got in place? What kind of expertise? What are the reporting lines those staff are going to have? What protocols exist to direct what staff are going to do when it's there? Is all of that led by the evidence, both in terms of research evidence and your evidence about what your client group needs? And is it set up for the context that you're in? Are you providing a service that's relevant to the people who are going to come through the door and use it? So that's the kind of organization bit to begin with. The second O is your operation. So this is basically what happens on a day-to-day basis. How does this actually things actually get done on a day-to-day basis? How do you manage risk and information sharing when that's necessary? How do teams work together? What's the culture like? Is it a sustainable model? Is it responsive to need? If need changes, if there's a diversity in the population, is it responsive to that? And how does this link out to other partnerships and pathways externally? If you need to be linking out to the NHS and social care, how does all that happen? So basically, on your day-to-day basis, how is all this working? What happens? And then the third O is outcome. Do we know that this is having a positive impact on the people who are using our service? Are our students coming in, accessing that support and going away after they've accessed it, feeling better? Are they more able to engage with their academic studies? Is their level of distress down? Is their mental health in a better state? How do we know that? How do we gather that evidence, and what tells us about that? And what tells us about what's not working? How do we know about those interventions that aren't working as well? Or maybe we have got a member of staff who's just gone off the boil and may need some extra support, maybe needs a break, maybe needs some extra development work. What would tell us about that? And then using all of that together, how do we ensure that ongoing improvement? How do we then use all of that evidence that we've gathered to actually inform what happens next? And that includes student voice. How are we listening to because this is really important, particularly mental health. Listening to the voices of service users is something that's generally been neglected over time, but is really important because, we have in the past in mental health services, generally outside of universities, we've done harm by not listening to the voice of service users when they were telling us, actually, this thing you're doing to me is horrendous. It's really causing harm to me. So how are we using student voice, the data that we gather, the outcome measurements that we've got to inform that ongoing improvement, and how are we then doing that in a systematic way, not some kind of ad hoc random when we think about it way, but how do we ensure that systematically that's thought about, and then we sweep that back around to thinking about, do we need to change our organization in any way? Do we need to think about the way in which we're operating, and then seeing what impact that has on our outcomes overall? I'll briefly share just about outcomes, because this is really important and has become more important as we've gone through the Charter Awards, just trying to help people understand all of this. It's really important to say that we cannot know that a service or intervention is safe and effective if we're not robustly and systematically evaluating the impact it has. You can have qualified staff, well-trained, really experienced, delivering an intervention that's got good evidence behind it, but it can still be a mismatch. It might still be having a negative impact on the people who are using it. It may be causing direct or indirect harm. And unless we evaluate the impact of that work, we have no way of knowing whether that's true or not, or whether what we've got in place is fantastic and actually other people will benefit from knowing about it, or that we've got something we can really build on here that will have a really positive impact elsewhere. So, as I say, research shows even qualified, registered, experienced clinicians can do harm. And so evaluation is the only way to check practice. Now, the standard way of doing this in lots of places is to use outcome measurement, particularly in the counselling world. We've had outcome measurement in counselling for quite a long time now. And we can see there's quite a lot of evidence that using outcome measurement actually in a proper way, using it as a clinical tool as well as to gather evidence, can actually improve outcomes overall. Really important to say that, this isn't saying that outcome measurement in itself is always wholly accurate. We know that it isn't, but in aggregate, it gives you more or less the right answer about what's happening. And it's also really important to say that the way outcome measurement is used in either the therapy room or in the mental health intervention is really important. If we treat it as admin that gets in the way, then it potentially can have a negative impact. But if you treat it as another way of the student giving you important information about what they're experiencing, that actually can be really beneficial and can really help that communication, really help build rapport and relationship, and actually really help improve the outcomes overall. Now, if you don't like outcome measurement, we don't say that you absolutely have to, but what we do say is whatever you use for the charter particularly, whatever you use, it has to meet the same standards of robustness and systematicness. So, we have seen in some occasions where people are going, well, we gather qualitative feedback from students who've used the service, but it's like less than 10% of the students who've used the service, and it's very limited in what it actually tells us. That doesn't really meet the same standards and criteria. We also would generally recommend, if you are using outcome measurement, that you look to use it session by session if possible, because we know that gets you the best overall gathering of data. And that what you look for is significant improvement and/or recovery. Those are kind of the key thing. What is that telling you overall? Are the bulk of your students who are using the service getting better? And then also look at your deterioration number. Are many of your students actually going backwards? You would expect some to, because that's life, but you wouldn't expect it to be a very big number. Also important to say, we don't just want to see outcome measurement. We also encourage, again, that gathering of qualitative feedback from students, getting that student voice, and also listening to the expertise of the clinicians who you employ. Not just taking these numbers, cold, hard, black and white numbers without context, but actually talking to the staff in your service to say, okay, what does this mean? Where does it line up with your experience? Where does it not? Why might this be the case? And trying to understand, if there aren't as many students seeing improvement as you would expect, why is that? Maybe have you got a population with a really high level of distress and high levels of risk? Because that might tell you something that you need to think about in terms of your service overall. So let's look at those elements that we talked about earlier on then, that we thought kind of are part of good governance of our services. So the first one being staff, and making sure that we have the right staff in place and in the right roles. So we want to make sure the staff are appropriately qualified and registered with a relevant accrediting body. So you've got professional staff in professional roles, and we're not asking unqualified staff to take on work which is not safe for them to do so. We also want to we should be ensured really that staff are getting regular supervision. Ideally, this should be separate from normal line management. Ethically, that is good practice to ensure that it's different from line management, but so that they've got somewhere that can continue with their ongoing development. They can reflect on their practice. They can reflect on the people that they're working with to make sure that their interventions are good and having a positive effect. Really important to say that all staff really should be engaging in regular CPD, and particularly recognizing that student mental health is a specialism. So thinking about those things that particularly impact on student life and student mental health, and ensuring staff understand those and are able to work with those. A culture of openness is really important for good governance. Where staff feel that they need to hide mistakes or are worried about blame, that's really bad for safety. That's really bad for the effectiveness of the service. Harm is much more likely to be done to any client or patient accessing a service where staff feel that they have to hide mistakes or feel that they're going to be blamed. We need to see mistakes as opportunities for learning and for development, where we can discuss and talk about them as teams and not worry about that. That actually makes the whole service overall much safer. And as part of that, it kind of links to that really, that the culture of the team has what we call a low power distance. In other words, where staff can correct managers, where decision making is collaborative, and where there aren't hierarchies of power whereby the final decision sits with the person who's highest up in the management hierarchy, even if they don't have the expertise to make that decision. If that expertise sits elsewhere, maybe the decision's better made elsewhere. So where a member of staff can say to someone, in a management role above them, actually, I think you've got that wrong. Can we talk about that? I think that might not be right. Again, that's much more likely to lead to better decisions and to the avoidance of mistakes that could cause harm. And of course, also crucially important, but part of this, we need our staff to have good well-being, because as the metaphor goes, you cannot pour from an empty cup. Our staff working on that front line with students, if their well-being isn't good, that's going to impact on their ability to focus on the client in front of them, to be creative in the work that they do, to be able to work with complexity and risk when it presents itself. So they need to have that spare capacity to enable them to work and perform to their very best. Now, connected to this, obviously, of course, is the leadership that we provide within services. It's not necessary that the head of a student services team needs themselves to be a clinician, but it is really important that they engage with and understand the role of clinical governance and the role of the staff that they have in those kind of developing that governance and in the roles that they provide. Also important that if you're managing a service, that you understand the registered professional bodies that your staff are signed up to, and the requirements that they'll have to fulfill, and that things like CPD, engagement supervision, and the ethical requirements of those professional bodies, and that all that's considered in the design of the service and the way that the service operates. We do need leadership to take responsibility for ensuring that the working practices are safe and that the design of the service is safe and likely to be effective for its population. But to do that, then there needs to be a degree of co-creation. One, engaging with students who are using the service, but also then co-creating with the staff who are providing the service and listening to their expertise and the clinical insight that they have. And that the leaders prioritize staff well-being, that they see that this is a key part of their role, making sure that their staff are in the best possible place to provide that necessary support to students when they come through the door. And then also making sure that they're themselves are engaged in CPD, that their own knowledge and understanding of their responsibilities around governance and what their service needs to do is regularly updated so that they're not working with outdated models. And then there is a really important point here about how leadership need to link the clinical governance at service level to university governance at that wider level. Sometimes this is a thing that gets missed. There'll be broad governance of the university, there'll be potentially good governance of the service, but the two things won't connect. University governance won't recognize that it has this pocket of clinical governance within the institution that it actually needs to think about, and actually needs to think about in terms of risk and management and ensuring it's properly resourced and all of those things. So making sure the link between that wider governance and the service clinical governance is there, so that there's a broader recognition of it across the university, and people understand what the responsibilities of the institution are in ensuring that the service is safe and effective. Now, part of the way, of course, that we make sure that the service is safe and effective is by making sure that it's built on proper evidence. And I think drawing on a range of evidence is what makes this most effective. So in making sure that it's informed, first of all, by research. What is the research telling us about what's effective, what's helpful here? Are we, when we're generating new interventions or ways of working, are we doing that on the basis of it's what somebody thinks? Or are we doing it on the basis of the fact that we've looked at the literature, we've looked at the research, and we can see this is likely to be effective? And relevant guidelines. Are there guidelines out there that might actually help us to understand what would be helpful here, what would be useful in meeting the needs of our students? Secondly, the evidence from the service itself. If we take all those robust systematic evaluations, all those things, and adding to that things like university data and statistics, if we bring all of that together, what does that tell us about the need? What does that tell us about what our services need to do? And then this can be very specific at times. So if I think about some examples of universities where, for instance, a particular international student population has suddenly grown, and the service then engaged in trying to understand, well, what is it that these students are likely to engage with because they weren't coming through the door for those services, recognizing that actually the kind of westernized model of service that the university had was not going to be appealing to those students. And so therefore working with those students on the research literature and an expert in that area to develop something new that those students then did access. And you can see by that kind of systematic, robust way of engaging with all of that data, allowed them then to create that service that they were then able to evaluate and demonstrate the impact, so that they were sure that it was a safe, effective response. Clinical judgment is another important part of this. If you've got clinicians in your service, you've got lots of expertise, particularly if they've worked in universities for a long time, there's a rich resource of knowledge and understanding there that can be put to good use. And then also the context, as I say, of the specific university, a bit like I was talking about a moment ago. Is the student cohort changing? Other specific needs? I know, for instance, that from a disciplinary context, the different academic disciplines, students seem to respond in different ways. So some disciplines are much more likely to come and seek help than others. You might need to do much more outreach work with some groups than others to actually get them to come through the door and seek help when they need it, or to recognize and be willing to see that they need help. And that might be different then depending on the nature of your university. If you're a small specialist university, say with an arts student population, maybe you need to be adapting your services very specifically for that population, thinking about what it is that art students are likely to need and to present with, and then your service needs to build specifically around all of that. And what we want to see as well within all of this is that this is thought across the whole service design. Now, eventually, what of course we want to get to is whole university thinking, that all of this is linked out to the way the university itself operates. But what we want to try and avoid are different teams within student services working differently, not talking to each other, gaps in understanding, gaps in the way that students are spoken to, because that can create all kinds of problems. So we need to make sure that we've got cross-team working. So things, for instance, mental health teams, counselling teams, and disability teams. How are they working together? How is their work linked up? Where is the overlap? Is there a common approach across all of that? Are students getting a consistent message from all three of those teams, or are they different? Are they confusing? Are there gaps between those teams that students could fall into? And how can that all be addressed to make sure that it's a one team working, even though each team has its own specific role? So we want to see that cohesion between services overall, that there's a kind of one team approach across those services. How is the team culture doing with it? Is there a kind of hierarchy within different teams? Do some teams see that regard themselves as more important than others? What impact does that then have on the way staff feel or the way that they can input? And actually, sometimes what might happen is students may be telling one team about problems in another team. Does that get picked up? Does that get moved across? Is that part of your evidence gathering to inform that ongoing improvement? Are there policies and processes that are visible across the whole service? Does everybody know and understand what they are? Are the policies and processes used? Because sometimes what we find when we go into universities is there's a written process and then a process as done. This is a recognized thing within workplaces, the work as done and work as written. Is there a gap between what everybody thinks we're doing and what we're actually doing in practice? And what do we need to do about that? Do we need to address that level of cohesiveness too? And do we revise all of this in response to new learning? Is it updated on a regular basis? Is there effective triage? When students come to present, do they get to the right service at the right time? Are they directed to the right place? Are we reducing the number of times the student has to tell their story? Because we know from students having to tell their story over and over again can in itself become a barrier to them accessing support. And are we using the resources that we have for maximum benefit? Student services are always going to have limited resources. And what we want to do is to maximize the impact. Ethically, we really need to make sure that those resources are having as much impact on the student community as possible. So are we ensuring that our governance and our design and our operation is having the maximum impact on students that it possibly can? And is all that then leading into that driving of ongoing quality improvement? Are we using all of that to do really well-structured, regular audits of our process? Are we using ambitious standards to improve the support we provide? And are we doing that at all levels? Are we doing that at a service level, team level, and individual level? Are we bringing together all of that evidence we talked about earlier on, outcome measurements, student voice, statistics from across the university, from other departments telling us about what their experience is? Are we listening to the voices of academic staff when they're talking to us about their experiences of connecting with student services or what their students are telling them? And are we bringing all that together to think about the way in which we work? Are we including that clinical expertise to think about how we improve and how we move forward? And are we allowing staff to help co-create all of that as well as student co-creation? I'll talk about student co-creation in a bit more detail in a moment. Are we systematically looking for improvement? Or are we doing it whenever we get a moment to lift our heads and think about it? Is it built into our automatic processes that we are looking? Because it's generally better that services gradually evolve rather than every few years having to completely have a revolution to overhaul everything because things are no longer working. If we can gradually evolve in response to evidence as it's coming through the door, that's an easier process for staff. It's an easier thing to understand for students. And it's also much likely to lead to a more effective service overall. So as I said, student co-creation is an important part of all of this, ensuring that student voice is present. And sometimes what we see is consultation with students, where universities will design a service and put it together and then say, okay, tell us what you think. What was your experience like? Really where we'd like to get to, and the ideal place is where student voice is actually involved all the way through, right from design phase. So if we're engaging with students regularly, saying, so tell us about how might the service be structured more differently? How might it be organized differently? How might we operate differently? And that's not to say that students are always necessarily going to be right in what they recommend, but in their recommendation, there will be something about their experience or the experience of their peers that we can learn from. And we may do something different from what they initially recommended, but we'll be using their voice and their experience and thinking about how we did all of that. So do we have ongoing feedback mechanisms? That's also really important, because if a student has a negative experience, is there a way for them to tell us that they had a negative experience quickly, and for us to recognize and respond to that? Are there complaints processes? Are there really well advertised opportunities for students to say, actually, I have a concern? Or is that kind of buried away somewhere? Are we using outcome measurement? Because outcome measurement is a way of gathering student voice and gathering up about their experience. And we've also seen in some universities are co-creation panels and projects that involve co-creation. Co-creation panels, which are kind of a permanent thing. Obviously, students change, the nature, the people on the student panel change over time. But where student services teams will have a co-creation panel, and they will talk to regularly about, what are you hearing that works, what doesn't? We're thinking about doing this. What do you think? We're seeing this problem in the student community. What do you think is going on there? Can you tell us more about that? What do you think we need to do about it? So that there's more rich learning from students as a result of that. And sometimes specific projects to develop specific interventions where students are being involved right from the very beginning, to make sure that the eventual intervention that comes out at the other end is relevant, more likely to be picked up by students, and more likely to be effective as a result of all of that. And then sometimes what we see are research projects, actually full-blown proper research projects, to properly understand the student experience and to gather student voice to inform then ongoing development and ongoing improvement. And then finally, two kind of key things in this, which are really important to think about, and which are two kind of separate themes in the charter itself. The first being risk management, and risk, thinking about that risk in two different ways. The first is about effective, clear responses to presentations of risk. So if a student comes into a service and they are talking about the fact that they're at risk, or that someone else is at risk, what do we have in place? What have we got? How are our staff responding to that? Are staff well supported to do that? And so on. And then the second element of risk is making sure that the interventions and services that we're providing are not themselves presenting a risk to students. So those two separate things, and sometimes I think people can get mixed up when we're talking about risk. One is about the risk that students are already carrying and that presents to service, and the second is about the risk that we can present to students if our services aren't safe and effective. So thinking about all of this in terms of, have we got clear strategy? Do we have strategies for managing risk? Do we have, for instance, a suicide prevention policy or strategy? Do we have processes that everyone knows about? Are our staff trained in up-to-date responses to risk? And is the training that staff received, is it in line with up-to-date evidence? Is it in line with the national guidance if that changes? If evidence around working with risk changes, how quickly can we respond to that and make sure our staff are updated? Do we know that staff are in appropriate qualified roles? So, if in those places where students are most likely to divulge that they're experiencing risk, is the member of staff that they're likely to be talking to someone who is properly trained, qualified, and do they have the support around them to ensure that they're going to be able to respond to that risk effectively and safely? Is there a workplace culture that allows staff to seek support if they need it? So if a member of staff's working with a student and they've got some concerns and they're not quite sure, is it okay for them to go and find somebody else and say, can I just borrow your brain? Can you just help me? This is what's just occurred. I've just had this conversation. Something about it's niggling with me. Do you think I need to do something else? Rather than them feeling like if they expose themselves in that way that they might be criticized or shouted down, that it's recognized that actually that's just really good professional practice. And of course, the resources there to help them to surface that and to review that decision-making and to make another decision if that's necessary. Monitoring outcomes for evidence of adverse effects. So if we suddenly see that a large number of students accessing a particular service or working with a particular member of staff are seeing big deteriorations in their mental health, why is that? What's going on there? Maybe it's a fluke. Maybe it's just that member of staff's got a block of students who are really in a difficult situation, but maybe something else is going on that we need to understand and we need to unpick to make sure it's not a problem. And do we have those links as best as possible to those external pathways? Do we know what the referral routes are like into the NHS and social care? Are we able to do as much work as you can do, and I'm recognizing that that's limited, to build relationships so that you're able to do quick referral wherever possible? so that students can then get to that appropriate support outside the university where that's the thing that's necessary. And then, do we review on a regular basis? Are there ways for staff to come together and review what's happened in their workload, to talk about what's going on, and for us to learn? But do we do case reviews that are about learning, not about blaming, not about accountability? That say, okay, well, in future, this is what we could do, or actually, you know what, maybe we need to bring in some more training, or actually, that process didn't quite work the way we thought it would. Maybe we need to change it and make sure everyone's aware of it. So are we doing that as a systematic way on a regular basis so that we're able to identify that learning and put it in place as soon as possible? And then the final thing, as I said, is about information sharing. We know that this is a big issue in the sector and something that people have been concerned about. We do absolutely know that there is a balance that needs to be struck here between treating student information with absolute respect and with appropriate levels of confidentiality, but also making sure that when necessary, we are sharing the right information with the right people at the right time for the right reasons to make sure that we're maintaining student safety. Now, all of those information sharing arrangements need to be compliant with legal requirements. And it's not a bad idea to get your legal teams to just check out the information sharing arrangements that you have in place to make sure that what you think is right with where the legal picture is right at this moment in time. And of course, also recognizing that sometimes that legal position can shift and change. But some things that can be really useful. First of all, that actually it's standard practice for all teams to work with students to mobilize all of their available resources, especially in instances of crisis, so that it just becomes a natural thing that it's not working in isolation with students. You're automatically thinking about who else have you got around, who else can help, whether that be if it is family or partners or friends, or whether it's other services, whether the student is in connection with other services, or whether it's their GP in the primary care that all students will hopefully have in place. That we recognize that working with family and statutory service and others can provide support for students with poor mental health. That sometimes that can be really beneficial, but not always. And for that reason, we have to place student autonomy as central to the decision making. And unless the student is lacking mental capacity, that we are respecting if they're saying, look, actually that person over there is not right for me. I know it may look like it, or no, I may have said at an earlier point that they might have been a good person. Actually, I don't think they are. And so we look for support elsewhere if that's the case. We absolutely need to make sure that on those occasions where we do need to override students' wishes and pass on information without consent, and there are occasions that will need to be done, and we know from the research that that is happening in universities all over the country, where there are occasions where universities are passing on information, even if the student doesn't want it to, that those decisions, however, need to be made well. And in order for that to be the case, it needs to be the result of appropriate, well-governed clinical assessment, that there's proper arrangements in place for doing that it's consistent with the national guidance and with law, that it's clearly justifiable, and that it is in the best interest of the student, because the student is at risk, and not doing this might otherwise increase that risk or result in an outcome that none of us want. Also, means that we're thinking about, what support's in place for the member staff who's having to make that decision. Are they again able to access other people? Can they work with another clinician or with a manager to actually just think through all of that to make sure that they're making the right decision, not just about the decision to pass on information, but also about who they're going to pass it on to. Are they passing it to somebody who's actually going to be able to do something to reduce the risk? Now, for all of that to work at that point, it's also really important that before students actually engage in any support or any of the interventions, that they're able to see privacy statements, that they're not given an opportunity to miss them, that they're there, that there are multiple opportunities to recognize it, and that data sharing agreements are in place where necessary, or working arrangements are in place, ways of working are in place, that allows that information sharing to happen, and that students are aware of that before they access any support. So all of these aspects are related to and support each other, and you'll find them throughout the Charter framework, and we'll look at some of the principles of good practice in a moment. And if you actually look at a lot of this, I would say that in most services, much of it's probably already happening, but not necessarily in a structured, thought through, interconnected way. It's probably there. Some of it just needs to be pulled together. But pulling it all together is really important, because what that then does is it gives you a really solid structure to make sure that your staff and your services are ready for the ethical challenges that will come through the door around risk and around information sharing and so on. And that it ensures that you're delivering a safe, effective service. And that in that way, Students are going to benefit from it. They're going to be kept safe. And the university and the staff in the student services team are also going to be kept safe. So the principles of good practice you might want to think about, there are kind of 6 in the support theme itself, which is about ensuring that services are appropriately resourced. That's important to all of this. Also ensuring that they're safe, that they're effective, that they're responsive to context, that they're accessible to all students, and that we have that good governance in place. All the things we talked about so far. And then 2 other things that we also talked about, which is ensuring that services are cohesive and that there's collaboration between services. And then finally, that there's cohesion and appropriate collaboration between support services and academic teams and actually other teams within the university, so that students don't get lost in the gaps between other parts of the university and the service, because where that happens, harm can happen too. So all of this then is really just to say, this isn't something to be scared of. This isn't like us asking universities to do something which is outlandish. It is really just about making sure that our services are organized in the best way possible for the students who are going to be using it, that they operate in a way which means that they're as effective and safe and accessible as possible, that we're aware of the outcomes that our work is having, that we can point to that and understand it, and that we can then respond to those outcomes so that we can then ensure constant ongoing improvement to the services that we have, that we're making the best use of the resources that we have, and that we're having the most positive impact on student mental health and well-being in our universities. And I know that's what staff and student services care about. I come from the student services world myself, and I know that that's what staff are absolutely committed to. And good governance is a way of ensuring that we can have the impact on the student community that we want to have, and know that our work is having the best impact possible. I hope all this was helpful, and that the other resources in the Library of Learning continue to be helpful. Do look out for for those of you on the charter program, the in-person days and the online training that we provide as well, alongside all of this to support you. And I hope to see some of you at some of those events in future. But for now, thank you very much.